from it. So this is a companion case. 62-year-old female who presented with sudden onset abdominal pain. She has prior history of primary biliary cirrhosis. We can see the liver is cirrhotic and mixed connective tissue disorder. So this is the axial CT on her coronal images.
So it's looking like a splenic mass and splenomegaly.
Yeah, any differentials that we would consider? I have an MR too.
Yeah, and the MR would be helpful. I mean,
okay, let's look at the MR images. So this is the axial haste. Let me turn off the graphics, they're distracting. So mildly like heterogeneous, but areas of hyperintensity on T2 weighted images. It's a very well marginated lesion. Looks like it is encapsulated. Has some scattered T1 hyperintense areas.
And thinking
restricting.
Concerning because of the restriction. Amar is saying Sant. I thought about a Sant, but usually Sant is usually like more T2 dark, and it could have like
yes. Yeah. I don't know. Sant is like an unusual. I have only seen cases in literature, and they're more like focal nodular. I've never seen a big Sant like this, and they're hypointense and hypoenhancing masses.
We lost your images. I don't see them anymore.
Oh.
So, I mean, the lymphoma, how old is the patient?
I think I accidentally hit on pause sharing. Can you all see the images now?
No, I still see your screen, but I don't see the images. Do other people see them?
No, we don't. Okay, now it's back.
We did briefly.
Should I share it again? 1 second.
Okay. Yes, Cookie, I can hear you. So Cookie was bringing up lymphoma. Great thought, especially that much restricted diffusion.
Yes, I'm sorry, can you all see the screen or no? I think having some issues here.
No, we can't.
1 second. Okay, I don't know why the images moved to this screen.
Okay, we can see them now. And Rupa brought up littoral cell.
Okay, so littoral cell, they're typically multiple nodules. So basically, the other finding here are these enlarged lymph nodes, but they're also necrotic, like the main mass. So if you see, the mass is very necrotic. All the lymph nodes along the splenic vasculature are also very necrotic. So this one actually turned out to be lymphoma. But here, like I was thinking of angiosarcoma in this case, just because, I mean, necrosis was the main feature, dominant imaging feature in this case, and it just was totally biased with that imaging feature and questioned primary splenic angiosarcoma. But I think the lymph nodes were the like the helpful clue in this case, and this turned out to be a primary splenic lymphoma in this case.
Yeah, that is weird how necrotic it was. Cookie, what made you think lymphoma aside from the restriction?
I mean, my experience with splenic lymphomas have been necrotic. I disagree with Steve. It's not uncommon. I have several of them. I mean, they're antidote. I don't have a study, but I've had several experiences with their necrotic.
And would you have put angiosarcoma in the differential?
I guess I would have liked to hear the age. I missed the age.
62-year-old.
Yeah.
62-year-old female.
Yeah, it's not that old. I mean, the angiosarc certainly isn't a primary splenic lesion. You know, you always want to think primary mets and lymphoma on everything. Primary mets and lymphoma. I put that in my mind when I look at a tumor. Think of the primary, think of a met, think of lymphoma, because lymphoma can do anything.
Yes, so I totally agree with Cookie, and this is, I mean, I had a small theory on this, and I'll see if she agrees with me. So basically, yes, those are the three top differentials, primary, Mets, and lymphoma. She didn't had any history of primary malignancy, and often with metastasis, with splenic metastasis, we know that, you know, it's often diffuse, like you should see metastasis elsewhere too. And like, so we didn't consider metastasis in those. So the two differentials were sarcoma and lymphoma. And one thing that I learned from this case, that usually like what we, um, lymphomas, we don't consider, like they're usually necrotic masses. We think of them as more solid, homogeneously enhancing masses, but splenic lymphomas can be necrotic and give rise to necrotic lymphadenopathy. So read some literature on this topic. Just have few presentation slides. So differentials for splenic masses, here have been some benign lesions here, lymphangioma, hemangioma, hematoma. Obviously, this looked very aggressive, so obviously not one of these. Littoral cell is benign, but can have a little malignant potential, but these are usually multinodular lesions, like these are multifocal lesions. Aggressive lesions are, again, like differential diagnosis based on whether they're hypervascular, and SANT comes in the category of hypervascular lesions. And in hypervascular, hemangiopericytoma and hemangioendothelioma are very rare. There are only like few literature cases that I've saw. I've personally never seen these cases. So that boils us down to angiosarcoma, lymphoma, and Mets. So angiosarcoma can be solitary or multiple masses. They are bright on T2 from necrosis. T1 hyperintensity is a good clue because obviously because these are angiosarcomas, they can bleed, so they can have internal hemorrhage, and they can have peritoneal, like capsular rupture, and then hemoperitoneum. They're usually heterogeneously enhancing. So the solid component shows intense arterial enhancement, and there are a lot of areas of non-enhancement from necrosis and hemorrhage. And often one of the things that I got from literature is they're usually metastatic at the time of presentation. So you'll often see liver metastasis, and this patient didn't have any liver metastasis. Moving on to lymphoma, they're more hypodense, either mass or masses. And the biggest clue to diagnosis of lymphoma is associated lymphadenopathy, which this case had. But again, angiosarcomas can also have necrotic lymph nodes, but they're usually restricted to the splenic hilum, just local metastatic lymphadenopathy. But if you see widespread like lymph node enlargement elsewhere in the abdomen and pelvis, then lymphoma is high on the differential. And then primary splenic lymphoma can be necrotic. And Mets, primary splenic Mets are uncommon, and half of them would be from melanoma, and then followed by breast and lung. And she didn't have any history of any of these primary lesions. They can be solitary or multiple, and usually you'll have widespread metastasis elsewhere too. And then more differences between angiosarcoma and lymphoma. I think this is what an important learning point is here, is that primary splenic lymphomas can be necrotic. They've and usually lymph nodes is what your clue is on imaging for diagnosis. And then for angiosarcoma, they're often metastatic at the time of presentation. And if you have T1 hyperintensity from hemorrhage, that's another clue for diagnosis. Okay, so that was the first case.
Great case, great points.
Okay, the next one is also, it's more like a companion case what Aarti had shown, but many days ago. So 81-year-old male who presented with intermittent episodes of nausea, vomiting, and abdominal pain. They did a CT first, and they found something, and to confirm that they did an MR. So these are the axial haste images. The pathology is along the GI tract.
Yeah, it looks like he has some like T2 dark concentric thickening of his duodenum.
Yes, that's the finding here. So we have a semicircumferential thickening along the descending portion of the duodenum, very homogeneous, very T2 dark. This is the arterial phase. And we see that thickening here, not very intensely enhancing on the arterial phase. And this is the portovenous phase and show some heterogeneous enhancement. And I have TWI images and show some restriction. So the detailed story on this patient is he actually presented with pancreatitis, and then they discovered the duodenal mass on CT. They did an upper GI endoscopy. It showed something, and all that workup was done at an outside hospital, and then he was referred to our place. And the physicians, the biopsy was benign in the beginning, and the physicians were not convinced that this is something benign. So they did MR and they repeated the biopsy. Any thoughts on what this could be?
The T2 darkness makes me think of a leiomyoma, but
Okay.
I've never seen one like concentric like that. It doesn't look as gray as like usually an adenocarcinoma. A GIST could be in there, but usually not this dark. Amar's bringing up focal autoimmune pancreatitis.
Mm-hmm.
Harish, pancreatitis.
No, so this turned out to be, so the initial biopsy on this one, which was benign, said it was just benign duodenal mucosa with hypertrophied Brunner's glands.
I mean, it could be lymphoma too as well.
Because of restriction. Yeah, that's a good differential, but this actually just turned out to be a well-differentiated neuroendocrine tumor. The only, I have no explanation for why it wasn't very arterially enhancing, but this turned out to be a well-differentiated neuroendocrine tumor. So it's just some quick.
Yeah, I think for that location, we should have brought that up.
Yes,
Yeah.
for that location, yes. And if you have a nodular mass and along the upper GI tract, I think that, and with restriction, I think I always like restriction for neuroendocrine tumors. If something is homogeneous and it's restricting along the GI tract, lymphoma and neuroendocrine tumors are your differentials. So, and this was a well-differentiated neuroendocrine tumor. For neuroendocrine tumors, they, based on this WHO, this is the WHO grading for neuroendocrine tumors. It's either a low grade G1, intermediate grade G2, and a high grade G3 based on the number of mitotic figures. And they do this, what is known as KI 65%. And some quick points about duodenal neuroendocrine tumors. They are clinically and pathologically distinct from other small bowel neuroendocrine tumors. They either arise from gastrin-producing G cells, and that results in duodenal gastrinomas, or somatostatin-producing D cells, resulting in duodenal somatosinomas. And classic carcinoid syndrome from a duodenal NET is rare, and the gastrinomas can be either sporadic or associated with MEN1 syndrome that we all know that will result in Zollinger-Ellison syndrome. And these duodenal somatostenomas are predominantly in the periampullary region, and they can be associated with NF1. So this was a somatostenoma on path, and this was periampullary in location. And this patient presented with pancreatitis just because this lesion, because of its location. And it's known that these lesions may result in pancreatitis. They're usually solitary, small, and 75% of the tumors are smaller than 2 centimeters in size. In WHO classification, I think it might be interesting for Aarti because she's doing, studying a lot of pathology these days. So these are 5 different types: duodenal gastrinomas, somatostatin producing tumors, non-functional serotonin containing tumors, poorly differentiated neuroendocrine carcinomas, and gangliocytic paragangliomas. So these are like 5 different histopath types of duodenal neuroendocrine tumors. And your differential
paragangliomas in like I guess they're like cousins, but in this case, in
cousins,
part of.
But based on that bland appearance on T2, when you thought of a leiomyoma, I think even, I mean, they all look very homogeneous and poorly enhancing lesions on imaging. And the differentials for this would be Brunner gland hyperplasia. So this was actually thickened duodenum and had foci of well-differentiated neuroendocrine tumor in it. So I think it had some background of Brunner gland hyperplasia in it, and that's what was picked up on first biopsy. heterotopic gastric mucosa adenomas, adenocarcinomas, but they're more heterogeneous, GIST, lymphoid hyperplasia, METs, and neurofibromas and schwannomas. So all these differentials came up while we were looking at the images. But I think restriction is what is really helpful in these cases, and the location. Okay.
Cool.
And the last one is a quick ant mini case, not much of discussion on this. So I'm just putting these images in.
Some weird Besorb.
Or a lipoma?
It's a Meckles.
Yes.
Kidding, but Meckles likes to look like Besorbs. It's funny.
Yes, so it's an inverted Meckel's with a lipoma. Yes, Amar said it, inverted Meckel's. So Meckel diverticulum can invert, and the risk factors for inversion if there is an associated lesion. So if they have ectopic mucosa or if they have a lipoma, then they have a higher chances of inversion. So this was an inverted Meckel's with lipoma. Now a simple inversion without a lipoma can also look like an intraluminal fatty mass, because when it'll invert, it'll take its mesenteric fat along the mesenteric vascular pedicle along with it. So I just pulled up an example from literature. This is from radiology. This was just a simple inverted Meckel's without a lipoma. And this fat is from the mesenteric fat that it withdraws along with it. But this case, they had a proper lipoma associated with the inverted Meckel's. I think that's all I have.
Everyone likes your case. They said very cute. Great case.
Oh, thank you. Okay, I'll stop sharing.
Okay, Kedar, you want to go next?
Sure. I'm going to share my screen. All right, can you guys see my screen?
Yes.
Okay, so 2010, I'm just going to go through these. This is 2010, 2015, 2017, 2018 and 2019 look exactly the same. So any thoughts?
Renal replacement lipomatosis.
That's exactly what it is.
That's what Steve said too. And Amar said XGP, which is what I was thinking. So please tell us about renal replacement.
So we have experts here, so I should have probably not even shown this case.
No, we're not going to get intimidated by our experts.
No, it's beautiful. That's actually a beautiful case.
So couple of things that it's a rare condition, but it's characterized by fatty tissue proliferation in the renal sinus with marked destruction. So it's thought to be on the extreme end of the spectrum from renal sinus lipomatosis, usually unilateral. And diagnostic features basically are atrophy and destruction of the renal parenchyma. They can be associated with renal calculi. And these are the things that you see in the differential diagnosis: is lipomas, perirenal lipomas, retroperitoneal liposarcoma, and renal angiomyolipoma. And why it happens in certain people and not in others, even with the stones, I was not able to find that in whatever literature I looked at. So it was just a very cool thing that I had not seen before. This is the only case I've seen. But we have images right from 2010 to 2019. So
Very nice.
I want the case.
who wants the case?
Cookie.
He wants a case.
Sure, no problem.
Collector.
I can send it.
I mean, I think it's a teaching point too, because of the how it progresses. The progression of staghorn or struvite or infected stones can either go through the XGP route or it can go through this renal replacement route. And both of them actually end up having renal sinus and perirenal fat deposition. And that just tells you its chronicity to the point. But I agree. I try to find out what makes a stone, a struvite stone, because they're usually infected stones, go through the renal replacement versus go through XGP route. It's not there.
Yep.
Amar is asking if there are features to distinguish them from each other.
Distinguish
The XGP from the renal replacement. Is it just because the renal fat is like so proliferative here?
Yes,
That will go
yes.
down? Yeah.
It's fibrofatty tissue which is proliferative.
Yeah.
Yeah, and it's marked atrophy. It's not like the blown out calyces, you know, bear claw situation of XGP. This is marked atrophy of the parenchyma from, you know, from the pressure effects of the stones.
Yep.
Cool.
Okay.
Amar, you want to go?
Sure. Let me share my screen. Okay. You guys see my case?
Yes.
So this is an interesting case. This was a patient who presented with abdominal pain. I'll go over the images and I try to find more about this in the literature, but the literature is a bit haphazard. So I thought I'll have input from you guys. So right lower quadrant pain, the ER had questioned about typical acute appendicitis. So appendix was no appendicitis, but there was another finding over the coronals.
There is a segment of like abnormal thickened small bowel in the
Yes.
ilium.
Yeah, some of the distal small bowels, mildly thick walled.
So even I thought like that was the thing that caught my eye. So I thought it's just some enteritis or ileitis. I was about to sign it off when I thought I just thought I'll have a look at this section once again. So
Oh,
this
is there a fishbone in there?
So, there was this abnormality here, which caught my eye. Not very, not very well on the coronal, but on the axial, it's true. Like it's not an artifact, and I thought it's in the wall. So I said that this is probably a foreign body. Their initial plan was conservation, but the patient was continuously having symptoms. So they operated, and this was a chicken bone, which was
more rare than fish.
Yes, yeah. We asked them, like we said that it can either be a chicken or a fish bone. But so this
Amar, did they actually say it was chicken? Because my pathologist won't tell me. When I've had several of these now, and they would be like, "We can't tell if it's a chicken or a fish."
So what happened is that I asked the surgeon, like I was very excited because I found this and I just saw these, like I've seen this in on case conferences, but the surgeon was not very excited. All he told me was that it was a chicken bone. That's what he said. I didn't check the histopath, but I'll check that and I'll get back. But that's a point that I was not aware, that the pathologists don't commit towards what kind of bone it is.
Yeah, they told me they're not zoopathologists and they can't tell.
So in terms of like literature, like there's not much written about these. So I thought if you guys had any points to add to this case, your experience.
You're lucky when you spot the small, tiny little bone fragment. That's my recommendation. And one time I had a foreign body reaction where there really wasn't much to see, and it's because it was a plastic toothpick shard.
Right.
Which was like basically not visible other than, you know, in retrospect, maybe you see something like, looks like a linear piece of gas almost.
Right.
Yeah, we've had several fish bones and toothpicks, and the toothpicks are hard because they can be like, even the wooden ones are like loosened.
Yes.
But I find that, yeah, if you look at, if you're lucky enough to pick it up like this, and then you start to look at the other like reformats, then usually you can make it into a linear structure.
Right.
But great pickup.
Yeah, that was my
sometimes you can get also this wire barbecue brush bristle that can look like that.
Nice.
Maybe more in Arkansas.
Yes.
That's a real good pickup because, you know, the foreign bodies I've seen have been some sort of reaction. I mean, stranding, edema, so your eyes start looking at it and then you pick it up, but you picked it up and then looked at it. I don't think I would pick it up. It's great.
We had one that went out of the duodenum, third portion of the duodenum, and actually caused a whole thrombophlebitis and thrombosed off the entire SMV.
Oh my.
Mm-hmm.
Yeah. Thank you. Yeah, that was my case.
Cool. Ross, want to go?
Yeah, I'm sorry, give me 1 second here to try and get this to work. Yeah, here we go. Okay, so this is a middle-aged guy who came into our ED pretty recently, actually. So one of our residents was reading this case, and you know, initially, I don't know if I need to get feedback on this, but it sort of looks like there's some sort of obstruction here, of course, right? So our resident was trying to figure out where the transition point was. You can see some pneumatosis most likely. And he was pretty confident that he found it in here. And so the question then became, why is this guy obstructed? This guy had no surgical history, no real past medical history to suggest that he would have obstructions. And so does anyone see what might be the cause here?
Kind of a funny configuration of bowel, like there could be an internal hernia maybe.
That's actually what I sort of thought when I saw this case initially, but then, but that's not what it turned out to be. So no internal hernia. And I have surgery in the path to show you what actually caused this, but this is probably the best view here.
I think it's right on that image.
Yeah, this is a pretty good one right here.
Amar's asking for about volvulus.
Yeah, no volvulus that we could see.
Omar is asking for congenital malrotation.
Yeah, I think everything looks pretty good. Like duodenum crossed over, colon's in the right place.
Can you keep scrolling through that area?
Yeah.
Like, what is that little? Outpoaching.
Yeah, sort of this thing here, if you guys can see my.
Not just adhesions?
No adhesions. He had no surgical history and nothing really that we.
And that could be a Meckel's too.
Yeah.
Are we close to the TI?
That's correct. So this turned out to be an amazing companion case for what Gitanjali presented earlier. So yeah, so we saw this, so the resident actually saw this little outpouching and a little bit of stranding around it, and this is right where the transition point was. And he actually suggested at the time of this read that this was a Meckel's diverticulitis causing obstruction. So this patient went to the OR, and we got some great intra-op pictures. So you can see the little outpouching here, which is the Meckel's diverticulum. They resected that part.
Full screen.
Oh yeah, let's see. Let me try. My computer will like put it on a different monitor, I think. Let me just see if I can make this work.
It's okay, no worries.
Yeah, let me just try and zoom it up a little bit. Here we go. There we go.
Does your resident want to do body imaging?
I'm sorry. Does the resident want to do body? Yeah. I'm actually not sure. He's a second year, like just taking a call. I mean, it's an amazing call, like prospectively, but
Kind of like inflammatory reaction and adhesions in that neighborhood, huh?
yeah. So, and then fortunately the surgeons came down to review it that morning and knew that that's what we were thinking. So they took these great images. We actually have a few more to go along with it. This was the path. So the path confirmed it. And like I said, it's great, happens to be a great companion case, but I put a few slides up here just because I never remember my embryology. But early on in pregnancy, the vitelline duct is what gives the embryo sustenance from the yolk sac, so very early on. And ordinarily that'll of course like atrophy and close off, but it's not too uncommon to have a little remnant there, which is a Meckel's diverticulum. which can cause all sorts of problems. So here's, a table that I came up with, or that I found online that can show some of the things. Obstruction happens to be one of the most common complications. So it was a great case, and it was especially impressive because our resident called it prospectively.
Very cool. People in the chat box like it, and they said, nice rad path with optics.
Yeah.
Cool.
He was an enthusiastic surgeon who had just started in July, so.
Gonna find some additional atypical diverticulitis cases, then you can send something in for Cookie's radiographics.
Yeah.
Okay.
Always looking for cases.
I'm going to go next. This one is going to be easy for you guys, but anyway, it was this was a 35-year-old male who had no other past medical history, no real symptoms, some vague abdominal pain. This was the T2.
How old?
35. So we can see on this T2 that there's multiple targetoid lesions. This was the arterial phase on the left and the delayed on the right. So you can see that there's rim enhancement on the arterial phase and more kind of progressive delayed enhancement on the delayed phase.
There wasn't a CT to precede this?
No, not that we have in our system.
Neuroendocrine meds?
Great thought. And then this was the diffusion. So you can see that they're restricting, but like the restriction is more true on the rim of the lesions.
How sick is he?
We had hemangioendothelioma, a couple of cases which look just like this.
Yeah, epithelioid. Is he sick or not?
Hemangioendothelioma.
It was not sick.
Not sick.
Yeah.
Yeah.
And actually that's exactly what this was. So this was epithelioid hemangioendothelioma. So these are the classic kind of multifocal subcapsular targetoid lesions. Some of them can even cause capsular retraction. So for example, this one here is causing a little bit of capsular retraction. And so just a couple of teaching points about that. So these are rare vascular tumors. They have some features that overlap with hemangiomas and angiosarcoma. They are in the vascular family, so they're kind of in between these guys. They're locally aggressive and they have metastatic potential. 70% of the patients are asymptomatic. It affects the liver most commonly, or a combination of the liver and lungs, but it could also just present within the lungs or in the bones. It has a female predominance. It's usually kind of middle-aged. It can affect any age, but the median age is about 35. And nobody knows what the etiology is. There are some chromosomal abnormalities, but more recently they're also wondering if it could be related to Bartonella infection, which causes a vascular growth factor proliferation. And that makes sense to me, like as we think about Bartonella with pileosis as well. But they really don't know what causes it. And then just a couple more points about the imaging. So usually they're multiple subcapsular. They can have this targetoid appearance. Once they start progressing, it actually can become like large confluent lesions. But before that, they look usually kind of multiple and have this capsular retraction. And on pathology, the reason that the central part is kind of has more of that delayed enhancement and less restriction is because it's mostly this fibrotic stroma, with about 30% of them also calcifying. Whereas the more active epithelioid cells that are proliferating are on the periphery. So you've got this kind of like zone of active proliferation on the periphery with more fibrosis and fibrotic stroma centrally. So that was that case. I lost the chat box. So let me bring it back up.
The treatment for this is typically transplant. We've had 2 patients who had to get transplanted because they can be locally aggressive and metastasis.
Yeah, exactly. I did read in one paper that people have tried, no, I'm not able to pull up the chat, but that people have tried also radiation. So that's one other thing. And then this is my other case. So this lady, I was reading a follow-up scan. This was the follow-up CT. And you can see she's got a stent here going from her iliac vein to her IVC with a little bit of thrombus in it. And she also has these coils within her gonadal vein here. And so I looked into the history to see if she had a history of May-Thurner syndrome, and they said that she had a history of pelvic congestion syndrome. And so I was unclear about why they had put this stent in. I can't pull up the chat box, so can people just speak up about, do you know why they put the stent in?
Was it contributing in some way to the pelvic congestion? I don't
Yeah, exactly. So this is actually a combination of, this was a pelvic congestion syndrome that had been caused by May-Thurner syndrome. So I didn't know that they could go together. So just a couple of points here. So in this case, I was looking in the chart, it said pelvic congestion syndrome. This patient had had dull, achy pelvic pain, but also pain that radiated to her leg that was aggravated by stranding. So she had a clinical diagnosis of pelvic congestion syndrome. And then I pulled up the IR images, and I was still confused because what exactly they were doing here. But basically, my IR colleague explained to me that they power injected this left iliac vein, and this is one of the findings, which is that it was dilated. I basically asked the IR guy, like, hey, I don't see any indentation here from the iliac artery. And he said that often they won't necessarily see that there, but one of the reasons they use a power injector is because they want to kind of mimic when people are exercising or Valsalva, they want to put more stress on the system. So one of the findings that you might see is just this dilation of the vein, as well as reflux into the other vein. And then the other thing he said that is more helpful to them is that they do intravascular ultrasound. And on intravascular ultrasound, if they see more than 50% narrowing of the vein, that is diagnostic for them of May-Thurner more than these fluoroscopy images. So they did IVUS in this case. They saw that there was more than 50% narrowing, and that's why they placed that large stent. They also went up and injected the gonadal vein, and you could see that there's this huge dilated left ovarian gonadal vein here. So that's why in the end, they ended up putting in both the stent to treat the May-Thurner syndrome, as well as a series of plugs and coils to treat that ovarian vein that had been dilated because of the May-Thurner. So sometimes these can go together. So May-Thurner can cause a DVT. So when that right common iliac artery is compressing the left vein, you might get both dilation and classically a DVT. But you can also get pelvic congestion syndrome because you can imagine it's now refluxing up into the gonadal vein and into the other pelvic veins. So that was something I had not been aware of before this case. So I would share it. Cool, that's it for me. And did anyone else have cases? Scrolling back up to see. I think I got everyone. Okay, hearing none, I'm gonna end. Have a great day, everyone.
Good stuff, thanks.
Bye.
Thanks.
Thank you.